request Dr. Balasubramanian sir to take the session ahead.
Thank you. Let me share the screen just. Is my screen visible?
Yes, sir.
Yes, we can.
Okay. Thank you very much. I'm extremely delighted to be given an opportunity to share the sessions with my great friends, most respected Nitin Shah and Dr. July'2021. Thank you very much to the Alchem team. The topic for me is how do I suspect and manage MIS-C? How am I going to go about this session in the next 30 minutes? The focus would be primarily some cases from my personal file of MIS-C. We faced a large number of dilemmas. I will share with you the confusion we had. And we did have some solutions. I will share with you the solutions that we had for these dilemmas. And I will also share the data on MIS-C from our institution, Child Stress Hospital, and also share the protocol we are following for the month of July 2021 with a summary. Let us take you back to the first week of April 2020, very early days of COVID-19. Everybody was talking about COVID-19. Cases had come to India, and we had started our COVID ward. We were eagerly waiting for the first case. This was an 8-year-old boy who had fever, cough, fast breathing for 4 days. Like Dr. July'2021 said, the practicing pediatrician, one of my ex-students, he hospitalized the child. He did a PCR, it was negative. He took an X-ray which showed pneumonia. He appropriately treated with ceftriaxone. Being an 80-year-old boy, he gave coverage for atypical organisms with azithromycin. Day 4 or 5, this boy did not improve in spite of antibiotics. He developed some redness of eyes, rash, and became hypoxic and was referred to us. And what happened on examination, on arrival in our emergency room, his eyes were red like this, bulbar conjunctivitis. There was no discharge. And he had third spacing. He had rashes like this, very peculiar macular erythematous rashes. And he had cheilitis and he had glossitis. And he had a marked edema for the feet. And of course, we took the X-ray, which showed a consolidation in the right mid-zone. This is the story at that point of time. And we didn't know, what is this boy having? Is this boy having some peculiar disease? And we had no clue at that time. And in addition, you see here, he had abdominal distension, mild hepatomegaly, and he had ascites, as made out by the transversely stretched umbilicus. He had vague abdominal pain also, in addition to respiratory symptoms. To me, it looked like Kawasaki. We were not sure whether this is some atypical pneumonia. We are not sure whether this is COVID pneumonia. The outside PCR is negative. And we hit him hard. We sent him to the ICU, gave him antibiotics, piperacillin. We escalated to meropenem and doxycycline. And we are not sure what it is. The investigations, hemoglobin is 8.9, total count was elevated, and the lymphopenia was there. And platelets are high. CRP 317, which we have not seen quite often. ESR was 115. SGOT-PT was okay. Albumin with edema was 2.6. Renal function, sodium was 128. Blood gas was normal. Urine albuminuria was there. Ferritin we did 2000. Echo, immediately we thought of Kawasaki, got it done. ECG was normal. We are wondering how to treat this. At that point, we read through literature. There are reports of this so-called hyperinflammatory syndrome with COVID-19. Are we dealing with it? He is PCR positive. That time, mind you, no remdesivir. We had no choice at all. It was not available. So we treated him like Kawasaki. We started him on aspirin. We started him on aspirin 30 mg per kg, to be very frank to you. We also started giving him IVIG. And 2 days after IVIG, this fever never settled down. The CRP is still around 200, 250. At that point, we are reading literature that IL-6 inhibitor, tocilizumab, would be effective. And we took consult from our friend, Professor Ramanan, from the University of Bristol. He's a pediatric rheumatologist of international repute. We constantly got in touch with him. We got tocilizumab and we gave. It was a dramatic response. In 24 to 48 hours, everything crashed, and this is all history. So this was what turned out to be the first case of MIS-C. In fact, when we published it, we didn't even call it MIS-C because the Namakarna was not made by the WHO then. We called it hyperinflammatory syndrome with COVID-19, and this was the first case of hyperinflammatory syndrome, or MIS-C, treated it successfully with tocilizumab in international literature and in Indian literature. Then came the Namakarna. The Europeans and the Britishers wanted to call it as PIMS-TS, Pediatric Multisystem Inflammatory Syndrome, temporarily related to SARS-CoV-2. The WHO and, whenever Americans, whenever Britishers say something, the Americans will always say something against it. That's what happened. They termed it MIS-C. And mind you, all roads lead to Rome. You call it MIS-C, PIMS-TS, or anything. Almost the criteria are same. This is the label given to the Kawasaki-like syndrome in literature. And then 3 organizations gave 3 definitions. There have been subtle differences. I'm not going to go into it. For uniformity, we started following RCPCH initially, then started following the MIS-C. It so happened we had a flurry of cases, and we share our information of 19 cases with very good outcome. None of them died, and we treated all of them with IVIG. Very low incidence of coronary artery abnormalities was there, and we published a series with a lot of signs and symptoms. That was history. Case 2. Then what happened? This was a 2-year-old boy who had a fever just for 1 day. He had some diarrhea, and he had pain abdomen, and he presented with febrile status epilepticus, hypotensive shock, hypoxia, went into ICU. We just treated him with ceftriaxone, doxycycline, and acyclovir. He didn't improve. Fever was persisting. CT brain was normal, CSF was normal. And mind you, this boy also had low lymphocyte count, platelet counts were low, normal, CRP was sky high, ESR was high. Again, albumin was low, X-ray was normal, ultrasound abdomen was normal. We didn't know what to do. At that point of time, we had a dilemma. Is this boy having severe COVID in the midst of pandemic? Is it viral encephalitis or HSV? Mind you, CSF can be normal. Is it TBM, which is going to fool us? Or is it MIS-C? And what solution we had for him? He continued to have fever. He had shock. He had GI problem, diarrhea and vomiting. So more than 2 systems involvement. CRP was 100, more than 50 as defined by WHO. And of course, cultures are negative. We had no other obvious microbial cause of inflammation, including sepsis. COVID was positive. We made a diagnosis of MIS-C in a child who had febrile status epilepticus, mind you, with some diarrheal illness. IVIG, 2 grams per kg, MPS 10 milligram per kg for 3 days, complete recovery. At that point of time, we stored the antibody samples of antibody. Later, we proved that the antibodies were sky high also later on follow-up. Of course, just for research purpose. PCR was positive. He had all features confirming the diagnosis of MIS-C. Then Dr. Vijayavale is talking about remdesivir and antibiotics. In such cases, it is very difficult to withhold both. Dr. Vijayavale was saying WHO has removed remdesivir from the essential list of drugs. But what do the other guidelines say? If a patient is PCR positive, is acutely ill, serious manifestations, hypoxic, particularly within the 5 to 7 days, yes, you can consider remdesivir. Of course, I don't think I have the courage to withhold antibiotics in all these patients who are severely ill until I get a blood culture negativity. So infection screen need to be done in all such cases, and of course, particularly before steroids. Again, the American College of Rheumatology says you should give antibiotics. So you should consider remdesivir, but you did not give remdesivir unless it is PCR positive, with some bizarre manifestations or immunodeficient child. Antibiotics, of course, in any child who's ill with the diagnosis of MIS-C, it requires courage to withhold antibiotics. You should give antibiotics. In our center in Chennai, as a policy, we give ceftriaxone and doxycycline, but our incidence of soft typhus is very high. See, the bottom line, again, Dr. Shobal and Dr. Vasanthi published in Indian Paediatric, the first series of neurological manifestations of MIS-C in India. Any child, even with a primary neurological symptom, febrile seizure, atypical febrile seizure, 2 or 3 days of fever, even in the absence of respiratory symptom, it could be MIS-C, and we have to monitor the child for a possible diagnosis of MIS-C. The treatment is not antibiotics, it's immunomodulation. Case 3. This boy is a 12-year-old who had fever for 2 to 6 days. And the parents gave a history, the eyes were red on day 3. And they said there was a swelling in the right neck. He was treated by a pediatrician with amoxicillin. And day 6, the pediatrician had a doubt whether this is KD or MIS-C. And he was referred. Because the earlier counts are normal, CRP is only around 30. The first sample done on the second day of fever. Labs revealed essentially normal count, CRP is 45, renal function is normal, no hyponatremia, no hepatitis. Cultures are negative. And of course, thinking of echo and thinking of KD, an echo is done. So the dilemma in this boy, see day 5, day 6, the fever is coming down. He had some red eyes. It looks like MIS-C. Is this KD or is this MIS-C? The next question is, it's not only diagnosis which is in doubt, it's also the treatment protocol which is causing problem. Do we give him steroids? Do we give him IVIG? Do we give him aspirin? These are the dilemmas we face. Let us see how we can find solutions for these dilemmas. First of all, if you look at the history of MIS-C, MIS-C is a cousin of Kawasaki disease. If you know Kawasaki, you know MIS-C. MIS-C has some variations. There are some subtle differences. The main differences are all pediatricians, we are all used to seeing Kawasaki in young infants, particularly below 5 years of age. In fact, even in our own series of 200 cases in our unit over the last 10 years, we have had only around 15% above the age of 5 years with the diagnosis of Kawasaki. So it's not common above 5 years. On the other hand, MIS-C is notoriously a disease of older children. Not that it cannot occur even in newborn, it can occur. Rash in Kawasaki, yes, it does cause rash, but the percentage of children with rash in MIS-C has been far higher, nearly around 75 to 80% in our own series. Mucous membrane involvement, both the diseases produce involvement. BCG erythema is very characteristic of Kawasaki, is very unusual in MIS-C. But look at the differences in the cardiac involvement and GI involvement. You have more involvement of GI symptom, GI tract in MIS-C. In fact, quite a few children were referred as appendicitis, right ileal fossa, periumbilical pain. It turned out to be MIS-C. That doesn't happen in Kawasaki. Similarly, child coming with shock myocarditis is more often seen in MIS-C. It doesn't happen in Kawasaki. Kawasaki is unusual. Similarly, thrombocytosis, we are all used to high platelet count of 10 lakhs in Kawasaki. That is unusual in MIS-C. You often get thrombocytopenia. Leukopenia is more common in MIS-C. Leukocytosis is more common in Kawasaki. For the treatment, still it's the same. IVIG, steroids are not the first line for Kawasaki, whereas in MIS-C, steroids are becoming the first line. The problem for this boy who was 12 years old, who had fever, but who was settling down, echo was normal, and antibodies to COVID-19 was positive. Do we treat or not? In fact, we looked at literature. What does it say? Whittaker, one of the experts from Europe who published the first series in Europe, she had reported that, all MIS-C don't require immunomodulation. In her series, 22% of patients did not require anything. They all recovered. They have been followed up with echo. They have all been normal. So the American College of Rheumatology says, yes, in a minority of patients, you can follow up without giving immunomodulation. Only thing is, it requires a lot of guts. A team of experts should monitor him. And of course, certainly follow up the echo. Aspirin in such cases is recommended worldwide. The message is, all MIS-C don't require steroids and or IVIG. With having discussed these three cases, let me take you through the protocol we follow in our institution. Because we follow only the WHO criteria now, which says age below 19 years, fever of 3 or more days. Now, in fact, we have had a case which we picked up on day 2 itself. We diagnosed MIS-C. Of course, we waited for 1 day for confirmation. So you can pick it up early if you, just like Kawasaki, it need not be always 5 days of fever. You can pick it up early also. And 2 of the following mucocutaneous manifestations. 1, hypotension or shock, very specific. Features of myocardial dysfunction. Elevation of pro-BNP, which is considered very, very significant if you do. Coronary abnormalities in the echo. And of course, coagulopathy. This is a second line, PT-PTT abnormality, elevation of D-dimer. This is a very dicey criteria. We use it only for second line investigation. And GI problem. This is very, very important. Appendicitis-like presentation without respiratory manifestation, with some mucocutaneous manifestation, should make you suspect MIS-C straight away. We should not think it is typhoid or appendicitis. We should open up the child without a good diagnosis based on ultrasound and clinical features. And then elevated markers of inflammation. In fact, in our own institution, we have stopped doing ESR. We do only CRP because ESR is not going to add any more value. Procalcitonin, we hardly do it except in ICU setting. It has not been found to be of great use in MIS-C. So we restrict only to CRP. And of course, no other cause. This is very, very important. This is what Vijay has stressed. There should be no infection. The moment you diagnose an infection, you get a blood culture positivity, you prove TB, you prove UTI, you prove dengue, then it is no more MIS-C. Of course, they are reporting MIS-C with dengue. I'm sure in future they will report MIS-C with TB, MIS-C with typhoid, etc. But right now, if there is a proof for infection, obvious infection, other than SARS-CoV-2, it should not be labeled as MIS-C. This is very, very important. And of course, evidence of COVID-19, this is where the problems come. You have PCR positivity. You ask yourself, is this severe COVID or MIS-C? Again, it is clinical differentiation, not lab differentiation. Second is antigen test positivity. Yes, it is taken as a criteria for positivity. Serology, this is where the problems arise. Everybody gets a serology test done, suspected MIS-C. Just because serology is positive doesn't mean it is MIS-C. Because right now, in India, you expect 50 to 60% of children to have seropositivity. So they may have typhoid, they may have UTI. Just because they are antibody positive, it doesn't mean it is MIS-C. So contact history is something very important, particularly before 4 to 6 weeks. The latent period following SARS-CoV-2 infection MIS-C is said to be around 2 to 8 weeks. In our own series, most cases have given a history around 4 weeks before the presentation. For convenience, we have divided the cases of MIS-C into non-life-threatening and life-threatening. Don't ask me for reference, because this is being used in the IAP guideline and in the Lancet guidelines also. We are using this of late. What do you mean by non-life-threatening? Absence of shock or any end organ dysfunction. This was actually called as febrile inflammatory status last year, but now the term is gone. So we are trying to see if this term is going to stick on or not. So a child stable who has features fitting in with MIS-C, absolutely no shock, no organ dysfunction, end organ dysfunction not there. We want to call it as non-life-threatening disease. Mild, moderate MIS-C, severe MIS-C has not come into literature. So until then, we will use this term non-life-threatening disease. Life-threatening disease, very obvious, multi-system dysfunction, shock, respiratory failure, etc. There may be something unusual like HLH-like picture, unusual like renal failure, all that can be called life threat. So what do you do? What do you do? In our center, one who has non-critical symptoms, we do only level 1 workup. And we simultaneously work up for infection. That is something which is very, very important. We still can't differentiate clinically infection from MIS-C confidently all the time. And we do level 2 tests only when there is a high suspicion or we have made a diagnosis of MIS-C. If MIS-C is not confirmed, then we go by the usual protocol and re-evaluate the child after 1 to 2 days. And if the fever persists, we again have a look at the whole gamut of investigations and then find out whether it is MIS-C or not. Child with critical symptoms, we stabilize the child, we do level 1 and level 2 tests and work up for common infections. What do you mean by common infection? Vijay Valer nicely pointed out. We do antibodies for scrub typhus, routinely, dengue, antibiotics. Of course, here we go by clinical judgment and periodic review with labs, continue or discontinue antibiotics based on the reports available, maybe after 48 to 72 hours. But I can tell you, 100% of cases which went into the ICU in our hospital, they all received antibiotics. But then we de-escalated nearly about 95% of them after a few days. So the tier 1 investigation, very simple to perform. CBC, including a peripheral smear, differential, LFT and RFT. This is important because you may get elevation of OTPT, you may get hypoalbuminemia, you may get hyponatremia. Very important to look at the lymphopenia, presence of lymphopenia and neutrophilia. CRP alone we have started doing. And of course, we test for PCR for SARS-CoV-2. And if they had given an already a positive report 1 month back, we do antibodies. Or in the serology, we don't perform routinely. The PCR is positive, we don't do serology. The PCR is negative, we do serology for IgM and IgG in our own lab. If the CRP is more than 50 and at least one other laboratory clue, this is very, very important. When you have an absolute lymphocyte count less than 1,000, platelet count less than 1.5 lakhs, hyponatremia of less than 135, neutrophilia of more than 7,700 neutrophils, and albumin less than 300, then what we do tier 2 investigations. So this is the basic investigations we do, and then we go on to tier 2 if the tier 1 suggests that it is obviously something which is something to do with MIS-C. Tier 2, of course, we do an ECG and echogram, and even in tier 1 we do echocardiogram, because if it is a child with mild symptoms, if the echocardiogram picks up abnormality, then we treat it. If the child is stable, asymptomatic, otherwise ECG echo is normal, we try to defer immunomodulative therapy. We do ECG echo pro-BNP more than 400 picogram. It's very, very useful marker of myocardial dysfunction. Elevated troponin, less effective than pro-BNP. Ferritin, if you suspect HLH, prolonged PT-PTT, D-dimers, particularly in children who are obese and who are above the age of 10 years, we do. More than 550 nanogram per ml is considered as significant. Fibrinogen and LDH, we suspect HLH, not as a routine. Coming to the management, what do we do in our institution? In our institution now, what we do, we find out whether it is life-threatening or not. For life-threatening, what we do is to give IVIG. I'm frank in admitting to you, once there is a life-threatening disease, we do not have the guts to withhold IVIG, because there are, variable guidelines which say you can treat with steroid. At the moment, we do give IVIG, 2 grams per kg. Very importantly, of late, we have been giving the infusions in 0 to 12 hours unless there is a cardiorespiratory compromise. And we give IV methylprednisolone as a policy. We have been giving 10 milligram per kg at least for 3 days, maybe high dose for life-threatening. Aspirin, we give 75 milligram maximum unless there is thrombocytopenia or bleeding. And of course, we do give, as I said, ceftriaxone and doxycycline in most cases, in very ill cases. Children who have received antibiotics outside, we go in for big guns like meropenem and vancomycin. If the child has got a non-life-threatening disease, this is where the problems come. Absolutely no shock, no cardiac dysfunction, and it doesn't fit into a non-KD phenotype. Non-KD phenotype means child aged more than 5 years, who doesn't have a rash, who doesn't have BCG erythema, everything looks fine. In such patients, we consider low-dose methylprednisolone, 1 to 2 milligram per kg, IV or oral. I'll come to that later. If it is KD phenotype, here again, everything fits into KD, antibody is positive, then we go in for IVIG 2 gram per kg over 12 to 24 hours. And non-life-threatening disease, we give IBMPS only 1 to 2 milligram per kg. We have reduced the dose of late, and of course we give aspirin. So the difference is severe cases, yes, upfront we give IVIG and NPS 10 mg per kg. Non-life-threatening KD phenotype, we give IVIG and methylprednisolone, low dosage and aspirin. Non-life-threatening disease, absolutely stable child, either we don't give anything or we give oral or IV methylprednisolone low dose. Coming to the monitoring, we do monitor intensively. If there is no response after 48 to 72 hours with deference of fever, end organ dysfunction is remaining, shock is persisting, tachycardia is there, respiratory distress is there, what do? I told you our first case we gave tocilizumab. Now, 2 weeks back, we had a child who had neurological manifestation, who had right ventricular failure, who had respiratory distress, severe MIS-C, life-threatening, shock, came out of ICU, but still the inflammatory markers did not come down, fever did not come down, he continued to have cardiac failure. We did use anakinra for the first time in our institution. Thanks to Dr. Chandrika Bhatt from Bangalore, we airlifted the anakinra. On a Sunday morning, we gave 1 dose. It was dramatic. Within 24 hours, fever crashed. Child is well. Just after 3 days of anakinra, on follow-up is doing very well. So now we have changed. Previously, we used to give steroids and IVIG, then try tocilizumab. Now we have changed our protocol. Upfront, we use anakinra if there is no response after IVIG and high-dose steroid. We are trying to find out whether this can be done for the next cases. Of course, there are other alternatives. If there is a KD phenotype, we can give infliximab. IVIG, some things we do, we give very rapidly. And what we do, we give according to the ideal body weight. And we always take a sample, 2 ml serum and whole blood 3 ml for further studies for infections and immunodeficiency and other disorders. In future, we preserve a sample for research also. And one thing we do, if IVIG is not available, if IVIG is in short supply, today only 5 grams are available, and it has become very costly. Short supply is there in Chennai. I believe a lot of adult physicians have started using IVIG. That's the reason for the shortage. We believe IVMPS alone can be used after obtaining parental consent. And we, in our own unit, we restrict to only 70 grams based on the NHS protocol as the University of Bristol, though you can give up to 100 grams. We restrict to 70 grams. Over 5 years of age, if you don't give IVIG, it's not wrong. I personally believe you can get away with steroids alone. Steroids, we change to from methylprednisolone to oral prednisolone after 3 to 5 days. The child has got severe abdominal symptoms. We continue to give IV methylprednisolone even in low dosage for 4 to 5 days because the absorption may be low. We continue low dose methylprednisolone for around 2 to 4 weeks. We taper every week. We monitor with echo at 2 weeks, 6 weeks, 6 months, and 1 year. Enoxaparin, we follow the rheumatology guideline. We do not give routinely. We have given hardly for about 5-6 cases maximum. Some with obesity, some with prolonged shock, some with very low ejection fraction, less than 35. Only 2 children have had documented thrombus so far. We give it 1 milligram per kg BD subcutaneously, and the prophylactic dose, I'm afraid, is not based on IL-6 or D-dimer level. It is to be individualized. For non-life-threatening MIS-C, if improving spontaneously, we have had at least 5 to 6 cases. We do not give straight away. We do not give IVIG. We monitor as inpatient for at least 48 hours. Right now, I have a patient in my hospital who's afebrile for 48 hours without anything, who has classic features of MIS-C, very mild symptom. Immunomodulatory therapy, mind you, may not be required in about 20% of cases. Isolation precautions, if somebody is PCR positive, even if it is MIS-C, you have to follow. It's not needed for antibody positive cases. And as a policy in our own unit, we always, if the parents refuse to buy IVIG, we tell them you can go to a government institution, our own Chennai hospitals and government hospital IVIG is available, you can go. If they still refuse, we take it in writing, we get their consent and give only methylprednisolone. So far, we have seen 150 cases, touchwood, zero mortality. Most of them have received IVIG and high-dose MPS. Few have required spontaneously. Cardiac outcome has been excellent. We did the antibody studies in SARS-CoV-2, and last year it was 20%. Right now, we have collected samples. I'm sure it will reach around 50%. And almost 90% of the cases of MIS-C or PIMS-TS, all of them had very high levels of antibody titers. Then there was a question, there was a lot of talk of IL-6 being useful. So we did the plasma biomarker profiling and then we published it. We found very high levels of IL-6 in severe COVID, moderate COVID, in PIMS-TS. But mind you, then we also found that this IL-6 always correlated with high levels of CRP. So caution is that IL-6 need not be done routinely. It's enough if you do CRP. And you look at this slide from our data, you see very clearly that those children who required intensive care, they had a lot of complications cardiac-wise. Quite a few of them had coronary artery dilatation. Quite a few of them had myocardial dysfunction. And look at their CRP, very high levels. 177 is the mean level. Lymphopenia is frequently present. Nearly all those who went into ICU had hyponatremia. These were our findings. After a lot of controversy, there has been a lot of discussion in the net and in the recent articles on New England Journal about IVIG and steroid, low dose or high dose. Me and my dear friend, Professor Ramanan, we just discussed over phone for a few hours. We thought we should write up on this controversy of steroids or IVIG. And we wrote a commentary for the Lancet Rheumatology Journal. Only yesterday we got the news that it has been accepted. What was our question? Steroids or IVIG? The dilemma as first line in MIS-C, a crucial question in low middle income group settings. What did we write? We discussed the pros and cons of IVIG. The whole data on IVIG is based on data from Kawasaki. There is not much data. Until more data is available, while we await results, we concluded that pediatricians like you or me in India, to understand that it is reasonable to consider treating children with steroids alone as first line, withholding IVIG, which is expensive and difficult to access. And then we also mentioned that the recovery trial, which is ongoing in Europe, will give us the answers. What is this trial about? In PIMS-TS or MIS-C, they have 4 groups. One group, no treatment. Another group, IVIG. Another group, IVIG plus methylprednisolone. Another group, only methylprednisolone. Fourth group, IVIG, methylprednisolone, and anakinra or tocilizumab. And the results are eagerly awaited. I'm told it will come in a month. I'm sure we'll find answers. Meanwhile, we all know we have a lot of guidelines. IAP guidelines, which are released, the Lancet Commission guidelines, and recent DCGI guidelines, which recommends IVIG upfront. What do you choose? Mind you, these guidelines do have minor references, but they will not and they cannot offer solutions to every case we are likely to see. After all, children don't read journals. They don't present you typical features. So you will have to individualize approach to investigations and treatment in consultation with experts. To summarize, I would say to suspect MIS-C the first step, today, in any child with fever, irrespective of duration, you have to suspect. That doesn't mean every case of fever is MIS-C. Like Dr. Vijay said, our syndromic approach to pediatric emergency should not get clouded by the third wave and MIS-C. Just because MIS-C is there, every fourth day fever is not MIS-C. It may be enteric, it may be typhus, dengue, etc. Every case of severe COVID and MIS-C requires a very careful clinical approach, along with good investigation. Mind you, all antibody positive children do not have MIS-C. 60% are going to be antibody positive. And you can't diagnose MIS-C purely on the basis of antibody positivity. Remdesivir, I'm afraid, is on the way out, except in minority of children with MIS-C or COVID-19. Steroids alone, I predict, will become the cornerstone of treatment without IVIG for MIS-C. D-dimer levels are not necessary for you to decide on anticoagulation. They are going to mislead you. Just because it is more than 5 times, you don't have to give an oxapar. It's clinical judgment. IL-6 is a research protocol. Please don't waste money on it. CRP is good enough. Mild cases, if echo is normal, if you think it is MIS-C, if you confirm it is MIS-C, monitor without immunomodulation in consultation with experts. Do not start steroids for every child with suspected MIS-C, outpatient or inpatient. But all these controversial questions, I am confident recovery trial will come out with good answers in the next few months. Finally, MIS-C is a disease I like. You know why? It's like Kawasaki. It's like SOJA. It is not diagnosed with labs. It is diagnosed by the clinician. And it's a diagnosis of exclusion. The moment you diagnose some other infection, it's not MIS-C. However, beware of garden variety infection mimicking MIS-C. I'm predicting today we'll soon have revision of criteria for diagnosis of MIS-C. New definitions of complete MIS-C, incomplete MIS-C, atypical MIS-C, mild, moderate, severe will be there soon. Thank you very much. Please mail your feedback to sbspeed@gmail.com. Thank you very much.